topic is one where Dr. Thomas Crawford over here will show you a particular project, and I wanted to take a few minutes in advance to explain how it comes to be here in front of CSF. Those of you who've been coming to these meetings over the last 3 years have probably heard me and my son talk about the Perimeter Project. And we have given 6 presentations on it, and that's enough for now. We continue to work on it, but let me tell you briefly the context so that you see where this one's coming from. In the Perimeter Project, we're looking for edges. Why do I look for edges? Probably because of my wonderful PhD co-advisor, John Nysteun, who likes boundary dwellers. And I was taken with that idea many years ago, and I've always looked for edges. So the Perimeter Project started out, you heard me talk about the use of cemetery zoning as a way to protect fragile lands adjacent to Lake Michigan or any number of other places. Then we kind of morphed that idea into looking at the perimeters of golf courses as places for green burials. And that then got expanded into the world of tournament duplicate bridge, where that particular game, there's evidence that people who play that game into their later years in life have a way to extend the perimeter of their useful mental functioning. About that time, I also found Dr. Kim Eagle and Dr. Thomas Crawford, who were extending the perimeter of life in yet another way, using pacemakers to extend cardiovascular life. That led to a series of projects where we tried to integrate tournament duplicate bridge with the pacemaker project. And we were successful in getting a number of publications, and Sandy Western has some handouts for you. I'm not going to go through everything that's been done, but the handouts have QR codes on them to link to the different Perimeter Project presentations. So if you want to sit there with your smartphone, you can link to it, or you can do it later. Also, we produced American Contact Track Bridge League small cards about the Perimeter Project with a QR code on it in case bridge players who are 70 years old, average age of a tournament duplicate bridge player. There are over 160,000 of them in North America. They represent a very dense concentration of pacemakers. They're well off, they're well educated, they have money to buy the finest in medication, so presumably their pacemakers might even be desirable. So we distributed these cards at national bridge tournaments, North American Bridge Championships. I wrote articles that appeared in the American Contact Bridge League Bulletin, and various regional publications, applied for grants through the Gates Foundation, which haven't come through yet, but we keep at it, right? And other possible sources. So I thought today, instead of hearing more about the Perimeter Project, there is more, but I really wanted you to hear about this fantastic project that I've been privileged to join their team and go to their meetings with Dr. Thomas Crawford. Dr. Crawford?
Thank you. Thank you very much for the opportunity to talk to you. I manage a pacemaker reuse initiative at the University of Michigan. It's actually a project that was inspired by one of our patients, a lady in her 80s who had slow heart rates, which made her pass out. She received a pacemaker, and then several months later, she sustained a massive heart attack, which resulted in deterioration of her heart function, to the point that she not only had problems with the slow heart rate, but also with fast heart rate. And fast heart rates are life-threatening, and the treatment of choice for fast heart rates is defibrillator. Defibrillator can terminate life-threatening arrhythmias. All defibrillators can pace. And so this particular patient, after having had her pacemaker for nearly several months, suddenly required a different device, I guess a more fancy device in a way, that could do both defibrillation and pacing. And so when we were doing the exchange and the upgrade for the defibrillator, she asked, what are you going to do with a pacemaker that I have? She knew that it was going to last another 12 years, and we said, well, we're going to send it to the device manufacturer because that's what we're encouraged to do. And the device manufacturers do some type of testing on it, make sure quality assurance. But we were really, kind of inspired by this to look into the literature and, find out whether there's really any initiatives around there for the concept of reusing pacemakers. And just, I guess, as a matter of introduction, I want to say that cardiovascular disease really is the #1 killer in the world, despite the publicity that preventable infectious diseases get. Overnutrition is not the only risk factor for coronary disease, and certainly even populations with undernutrition or malnutrition still have high prevalence of coronary disease, which is the #1 killer in the world. And so cardiovascular disease accounts for about 20 million deaths in the world each year. And the burden of cardiovascular disease, as you can see here, is only expected to increase. And it is estimated by World Health Organization that about 1 million people die because they don't have access to pacemaker therapy. Cardiovascular disease is the disease that would damage the heart, the myocardium, and then the slow heart rates are essentially oftentimes a result of that damage. So it's a secondary problem that you have to address. And of course, there's huge disparity in the access to pacemaker therapy in the world. This statistics show the number of implants that are done annually per 100,000 population. I'm sorry, per million population. And essentially what this shows is that in the United States, we implant about 800 devices per million population each year, which is quite similar to Western European countries. We're not really an outlier. This is really where the advanced economies stand. If you can compare this with Peru or Thailand, where the number of pacemaker implants are 5 or 12 per million people. So there's certainly a huge disparity. So our initiative that we developed here at the University of Michigan, along with Kim Eagle and Tamir Bauman, one of our fellows, is that we really want to bridge this gap between the demand for pacemakers and their inadequate supply in the low and middle income countries. And what we see our role is as basically creating a blueprint for others to follow, or for a nonprofit organization to eventually grow out of this university project at the moment, so that we can actually have a method of acquisition, sterilization, device evaluation, sterilization, and distribution around the world. So the major partners in this endeavor are the University of Michigan Cardiovascular Center, which is what I'm the employee of this organization. Michigan Funeral Directors Association has really embraced this concept, and even though we currently really receive devices from all over the country, they're still one of our closest partners in terms of providing us with the devices and providing us with the industry-specific insights into this. World Medical Relief is an organization from Detroit, which distributes medical equipment to many countries all over the world. And so they have partnered with us so that they identify places that are in need of pacemakers, and they help us transport pacemakers to those countries. Implant Recycling is another Detroit-based organization. It's actually a for-profit business that has connections with the funeral industry and the crematory industry, and they receive metals from hip prosthesis and the like, and they melt the metal and are able to reuse it or resell it as a product. And then finally, patients and families nationwide who have agreed to donate their devices for this cause. So we'll talk about some preliminary safety data I will talk about patient and general population views about this concept. A little note about the funeral home director survey, feasibility of device acquisition, and the clinical trial that we're hoping to start soon that would be a safety and efficacy trial for pacemaker reuse. So the concept of pacemaker use is not brand new. When we were inspired by this patient to look into this, we actually did a literature search, and we found 18 studies ranging from 1970 to 2011 that have described their experience with pacemaker reuse. And we performed a meta-analysis to see what the complication rates are with reused devices versus brand new devices. And so this is the slide that's very busy, but it essentially shows you the 18 studies and the countries. They were done in countries like India, Sweden, Australia, Israel, Norway, Brazil. I mean, a variety of countries. You've got years mostly in the 80s and 90s, and the number of pacemakers that were studied. There's just a handful. That's why you need a meta-analysis to get a little bit better appreciation of, you have to pull the data in order to come up with some reasonable conclusion here. So there were almost 2,300 patients in this cohort. And when we did the analysis, we found that the risk of infection, which usually can be reported by 6 months, if the device doesn't get infected in 6 months, then it's not likely from the device itself if there's a secondary infection later. But we actually found that the risk of infection with brand new device was comparable to the risk of infection with a brand new device. So brand new device and old device, similar rate. The rate of malfunction was indeed higher by a factor of 6, which is not surprising because the pacemakers that were reused were obviously handled, went through several additional hands and were reprocessed. And certainly, it's a mechanism. Part of the mechanism is a set screw, and so there are a lot of things that can go wrong with it. Nonetheless, the pacemakers really are extremely safe, and there are millions of people who depend on their beat-to-beat basis, and so even the 6-fold increase in risk of malfunction is still quite acceptable, I think, when the option is not getting a device at all. So we did a survey in the Cardiovascular Center of the families that were visiting patients and patients themselves, and we asked them if they would be willing to donate their device after death to patients in the third world countries. And you see the responses of the patient population and general population. Between 70 and 87% of patients and their families felt like this is something they wanted to do. They also were willing to donate the devices to the manufacturer for technology improvement, which is already done without necessarily their input. And some were also willing to donate them to veterinarians for use in animal hospitals, since bradycardia is one of the issues that comes up with some animal species like dogs and horses. So then we surveyed the funeral directors in the 80-mile radius from Ann Arbor, and we got 90 responses. 84% of them said that they discarded pacemakers in waste or stored them with no intended purpose. So they were not doing what the manufacturers and what the FDA is currently recommending, which is that they're getting shipped back to the manufacturer for device evaluation and quality assurance. Only 4% of them did that. And again, overwhelming majority were actually willing to donate the devices if there's a legal framework that protects them and that allows them to safely donate the devices to those in need. So, when we receive devices, they're obviously of various longevity. Current pacemakers are last usually about 10 or 12 years from the inception, from their implantation time. Some other devices like defibrillators may last closer to 5 or 6 years. But so we decided that using a very conservative estimate of 4 years let's just say that if a device is going to last 4 years, let's just say it's worth implanting in someone. Which usually, depending on the device manufacturer, sometimes it's presented in terms of percentages. So it could be either 75% of the original battery life left or 4 years longevity, although the numbers are not entirely consistent across the industry. But what we found, this is data on the first 3,000 devices that we received. And among pacemakers, 15% of the ones that we received had that battery longevity. When we went to the other permutations of these electronic devices, which all of which pace, we found that, for example, with the fancy biventricular defibrillators, 30% of those devices still had sufficient battery to last for 4 years. So what we were hoping to now do is to perform a prospective multi-center study of safety and efficacy of pacemaker use, where we use a standardized and validated sterilization protocol, which we have already developed. We will enroll 500 patients and perform analysis at 12 months for complications such as device malfunction and infections. Perform longevity analysis, and we'll eventually follow those patients for up to 7 years. So in order to make this happen, we work with funeral homes and crematories. There's a process of consenting the family and explanting the devices. We have a website that it's MyHeart-YourHeart.org, which explains how to take a pacemaker from the deceased. Parenthetically, I should mention that all deceased who are cremated have to have their pacemakers removed, because apparently the pacemakers implode or explode in the crematory equipment. So while those who are buried in the ground do not routinely have their devices taken out, all the deceased who are cremated have the device taken out of their body as part of the process. So we certainly need a partner in the funeral home industry. We need legal counsel, which currently we have some support from the University of Michigan General Counsel to navigate this between the FDA and the regulations that govern biohazard shipments, for example. It is illegal to ship an adulterated medical device across state lines, so we have some issues with being able to export devices that are adulterated by virtue of not being brand new and re-sterilized. We, of course, work closely with Funeral Directors Association, without whose support we couldn't possibly do this. And there are several universities across the country that have shown a willingness to work with us and to identify potential sites for the projects and the distribution of the devices. And of course, what we need is a nonprofit charitable organization which could assess the qualifications and safety record of various implanting centers and maintain databases of all devices received and distributed, which is one of the issues that is very important, since devices, medical devices are subject to recall just like any other devices. And certainly if there's a recall of a medical device, it is the duty of the provider to alert the patient and figure out the most appropriate course of action. So that's why that has to be actually also kept. Of course, we need the implantation centers, and so far we have identified centers in 7 countries. We work with folks in the Philippines, Vietnam, Pakistan, Bolivia, Nicaragua, the Dominican Republic, and Mexico. And basically we are trying to work with the FDA on allowing us the official export of these devices for the study overseas. And of course with the Drug Administration, which has a stake in this, as you might imagine. So in conclusion, I think I've shown that there have been studies that suggest that pacemaker reuse is safe and reasonable practice. It appears that the general public, patients, and funeral home directors support this concept. 1 out of 5 devices that we receive have at least 75% of the original battery life left, because a lot of times patients get those devices implanted near the end of their life. And of course, if we can establish a validated pacemaker reuse program, it would transform this wasted resource into new life for somebody else that would otherwise not be able to have. Here's an email that I have received from one of the families that donated devices to our program. It says, "Dear Sir, Madam, my wife recently passed away, and one of her final wishes was that her pacemaker be donated for someone in need. At my request, our funeral director removed the device and I have the pacemaker. At home, our family would very much like to donate this device to a needy person overseas. Your attention to this matter will allow me to complete this final request." And then you can match this with a letter from the recipient who says, "I'm blessed to be helped by your humanitarian and godly efforts, which gave me hope in life. Truly, I have a happy life because you made me feel loved, even though you did not know me." So I just want to say that I appreciate the contributions that Dr. Kim Eagle and Tamir Bauman have done to this. Tamir is actually one of our trainees who has graduated and is now in private practice in Illinois. And I do really appreciate Sandy's contribution to the project and her initiatives with the big Bill Gates Foundation and all the different things that she has done. And as I mentioned, we had discussions with the FDA about allowing us to export these devices. And is it your cousin or nephew?
Cousin.
Your cousin, Frank Arlinghaus, along with John, essentially allowed me to talk to one of the Congress people who have oversight over the agency so that they don't forget that this is an important project. And so I appreciate the political support that stems from that. Okay. Thank you.
Now, John Nysteun will tell us a bit more about his adventures in following up with a conversation I had with Frank Arlinghaus in New Jersey this last June. And by the way, Frank sent me an email note a couple of days ago and said that he really wanted to be here, but he lives a mile west of Seabright, New Jersey, which is right on the shore. And he is busy with problems at home. So we'll see him another time. In the meantime, John can tell us about that meeting.
Well, can we ask a few questions?
Yes.
Yeah, sure.
Sorry.
Go ahead.
Thank you. It would seem that if you have an organ donation sticker on your driver's license, that could also cover devices of whatever kind that are implanted in your body. I'm guessing that it does, or that it doesn't do so?
That project is underway.
Okay, so that's...
It doesn't do so, but we do have contacts with the organ donation folks who are helping us, albeit somewhat unofficially, because the whole practice is not sanctioned. That there's no really parameter how to safely do it. The organ donation is, but taking a biohazard and then shipping it for a purpose that's not necessarily approved is somewhat risky. And of course, it depends on the risk assessment of the individuals that are working with us, some of whom are not risk averse and won't work with us. But we certainly have developed relationships with those folks, and we are trying to incorporate, for example, pacemaker donation into a living will or like a healthcare power of attorney. And so, we're trying to build up momentum for that, and hopefully this will eventually, be standard practice.
I hope so too. Sorry, one
Sure.
follow-up question. I'm assuming that the battery in a pacemaker is so closely integrated that you can't simply
That's correct.
remove it.
So we oftentimes use that term kind of loosely, that when we exchange batteries, it's really we're exchanging the entire electronic computer portion. The only thing that stays in the patient's body is the leads, which are like electricity, cables that go into the myocardium, into the heart. So yes, the battery itself is inseparable from the device, and as a matter of fact, in years prior, the devices really didn't last that that long, maybe not quite as long as 10, 12 years. It's a more recent development. And the main proponents of not having long battery longevity suggested that, you know, the devices are going to be so much smarter 4 years from now than they were, so that you don't really want a device that lasts 10, 12 years. But as I think that as costs and the fact that each time the device is replaced, I mean, there's some infectious risk. It really is now apparent that the devices should be made to last as long as possible, and the additional fancy things that can do are not really critical to their function.
I actually have two questions. Would you need trained personnel to take the device out at a funeral home?
No, and so I mean on our website we have a little brochure that explains how to do it. Basically we just request that the device has the leads, at least there's 1 or 2 inches of leads staying in the device, because in order to take them out you have to have a torque tool that is specific to the device. And so I wouldn't expect anybody to have that, and otherwise they would destroy those screws and that would be a major problem. So, yeah, so it's just like cutting the leads and basically removing the device from the chest. The pacemakers, I mean, pacemakers are in the vast majority of patients are implanted under the skin on top of the muscle. So it's not very deep in the body that you have to get into.
So there would be no added cost to the family?
No, there's no added cost.
Oh.
What is the cost of a new pacemaker?
So cost of a new pacemaker, you know, is negotiated between the manufacturers and the hospitals, and it's actually not public knowledge. I mean, because they all, you know, hospitals compete. However, I do have I work at the VA, and each time I implant a pacemaker, I do get like a prosthetics request thing, and so I actually do know how much the government pays for a pacemaker. So it's $4,500 for a dual chamber pacemaker and $3,700 for a single. And then there's also cost of the leads if you use one. I mean, it's about $500 per lead.
Wow.
So that's the cost that you could. Now the leads, of course, they're vulnerable to injury. They're actually ingrown into the heart muscle in a recipient. We could not possibly clean it well enough and ensure its safety. So we do not reuse leads. The leads have to be purchased by the family members, or like in this case for the clinical trial, one of the device companies has volunteered to provide half of the leads for the project.
And when you're looking at the global market for pacemaker use, is it the high cost, or just that they're not manufacturing enough, or what are the barriers for
The main cost, the main barrier is the cost.
the cost?
And then the secondary barrier is local expertise to treat the patients.
Are there any pacemakers being manufactured, let's say, in Korea or
Yes.
China now that
There
are
are-
cheaper?
There are pacemakers that are manufactured in India that we know of that cost about $800.
$800. So, and, okay. So it's just like the difference between a generic drug and a branded one, in
Yeah.
a sense, that a lot of the research money is coming back in at the high cost here.
Right.
Mhm. And when you're looking at distributing them now as a reused device, is there any cost associated at all in the thinking of it, or
Well,
there's
so-
the cost of having the procedure done? Is there anything else that would be a barrier if I needed it and I had nothing and I have no insurance?
So, I mean, none of the pacemakers that we donate are sold. Patients generally are expected, and their families are expected to buy the leads. By the way, the leads, Indians also make leads, and so they're about $150 each. So, in terms of our costs, I mean, the basic cost is the device resterialization, which we could do very cheaply for a few dollars in our facility. For the clinical trial, because we want to have a validated protocol and actually a company that re-sterilizes other medical equipment. And in order to do that, the cost comes up to about $50-$60 a device.
My last question is that in the 7 countries you mentioned for this study, you didn't mention India again, though it was in an earlier study. I was just curious, is it a political problem?
No, and actually that's where I would hope to perhaps gain some help from your organization. we have not had an opportunity yet to identify a center in India or find out whether the government is willing to do this. In order for the FDA to issue this permit, they actually require that this project is approved by the local health ministry. And so we ourselves don't have the political connections. And while we have talked to some physicians in India, it didn't get very far. And so certainly if
It's an area that maybe we can help.
if you could help with that, that would be tremendous.
Thanks. Just following up on that question, could you give us very quickly a profile of what an implementing center would look like on receiving end? What are you looking at? What kind of organization would you want to identify?
Right. So, you know, the organization, I mean, so what we originally wanted to do is to find facilities that already implant pacemakers for patients who are paying customers, because that's the easiest thing to do. You know, there are already physicians who do it. They get paid for it. The devices are purchased, and there's already some infrastructure. Now, that was originally our concept of it, and we realized that we really couldn't necessarily grow the project that way, is because there are countries in which there are no trained physicians to do that. There's no local expertise. And so we have engaged with several centers. Actually, I did mention Uganda and Liberia because we have not been there yet. And those countries, we will actually send physicians to train them how to do this. In terms of the equipment, what they need is an operating room that otherwise would be considered a sterile environment, and a fluoroscopy or X-ray, portable X-ray machine, which is essential in order to implant the device. So we need a sterile room, and we need, you know, somebody who knows sterile technique. And, you know, the pacemaker implantation is not that difficult. So the subspecialists or specialists that we approach are, for example, general surgeons in Liberia. They know how to get access into the vein. They're just not accustomed to putting pacemaker leads in there. So, you know, as you can imagine, it's just a few people at the university trying to do this, and so it's very difficult to actually have a large capability to teach people over the world how to do this type of thing. And you do want some type of rudimentary structure to be in place, because, you know, when patients show up in the emergency room with their pacemakers, there has to be some way of somebody somewhere in that area being able to address them and the complications of those.
What do we know about how widespread cardiovascular disease is? Do we have a certain set of countries that we particularly would like to target because of the need or because a critical center could be created there?
Well, so just out of convenience, we just want centers that can reliably implant devices, and we want to basically show that this concept can be implemented. We have not done much research into where the need is the greatest. That's something that also we could work with the organization. We're certainly willing to work with any country, and we're willing to send you know, some of our physicians and fellows, and especially that we have this network of academic medical centers that have a lot of fellows, and we have people. We can orchestrate groups of people traveling to different countries once the need is identified. So yes, if we go past this point of just a single clinical trial, when we bring it to a macro level, we definitely need an ability to identify the centers with greatest need, population centers with greatest need.
Why not Detroit as a recipient area?
Of the pacemakers?
Yes.
Oh, we would get jailed so fast.
Because?
It's completely illegal. It's No. So I mean, basically, you know, the FDA will not allow something to be carried out unless it's proven to be reasonably safe, and that proof has not been provided. Now, some people this is a natural next step. You might think like, well, if it's safe everywhere else, you know, why is it not safe here? Or are we willing to accept different levels of safety for different countries? And we will never try to make the claim that a reused device is as good as new one. I mean, it has been handled. The longevity is not as good, which means that, you know, every time we replace a device, there's 3% risk of infection. So it's not an optimal product. But if the choice is between not having it at all and passing out or not being able to sustain life because of the slow heart rate versus having a product that, let's say, has a 3% chance of hurting you, that's probably still a good deal.
Isn't there a population within the U.S. that would benefit as much as someone in Pakistan?
You know,
and is it possible to somehow approach that even now?
The truth is that when patients come to the hospital, which is typically when they need a pacemaker, it's not an elective thing that happens, you know, in the doctor's office. They get a pacemaker. We never looked at, you know, with 40 million Americans uninsured, a lot of them get pacemakers if they need them, and then somebody else worries about it later, which means probably they get bills, and they probably, you know, maybe, I don't know how the
it's not
companies,
so simple.
It's not so simple, but really, the truth is that even without insurance in this country, you know, when you meet a class 1 indication for pacemaker, you'll get one, no matter which hospital you go to.
And you get a new one.
And you get a brand new one, that's right. And basically, the people who pay insurance subsidize that in some way, or, you know, there's some cost shifting going on already.
In terms of not having the trained personnel on the ground, like you said in Liberia, surgeons to place a pacemaker in the recipient, could you partner with an organization like Doctors Without Borders? Would they have the resources there? The personnel-wise, or skills?
Oh, to implant devices? Well, yes, it would be one solution, but we do need people on the ground that can then follow up on the devices. See, we cannot just show up one day and put in the devices, but then you need to be able to have some people who can actually address a complication that occurs a month later, 3 months later, 12 months later, potentially, okay, or malfunction. So you really want to set up in place, you know, in the United States, when patients have pacemakers, they get a wound check in 1 week, they get a follow-up appointment in 2 weeks to look at the electronic circuitry, and then every 3 months thereafter. So patients are really seen at least 2 times a year in this country, which is what, you know, the standard of care is, to make sure that the device, the battery depreciation occurs at a predictable rate, and so that we know when the device is not going to be reliable anymore. And, you know, certain parameters do change over time as there's aging of the lead and the interface with the heart. So that the amount of electricity it takes to actually successfully stimulate the heart changes. So there's more to it than just dropping it off.
Sorry, can you tell us if it takes that every 4 years to do everything?
Well, if that's, we basically think that this would be like a reasonable, arbitrary, arbitrary time cutoff. You know, if we were very popular, and it is possible that you might have to make a choice that we don't have to do in this country, or make in this country, where somebody older may get a device that only lasts 4 years, somebody younger may get a device that lasts 10 years. You know, we have 10-year devices, and so we try to give those away first, but it's quite arbitrary, you know, how many years of remaining longevity you want to have. Okay?
Thank you.
John, you want to just a few minutes follow up there?
No, we're running late, and I think I should pass. I do have a couple of things that I would say, but I'll say it when we'll have breakout sessions. I can say something.
Okay, good. Thank you.